Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. We're very fortunate to have as our guest speaker a colleague and a longtime friend, Dr. Deepak Gupta. He's a graduate of the New England College of Optometry. He has trained ophthalmology residents, ophthalmic technician, and tutor optometry students. In addition to practicing full-time optometry, he's published more than 200 articles in optometric professional journals, has delivered well over 300 continuing education lectures, and he was the sole author of the textbook Glaucoma Diagnosis and Management published by Lippincott. He has extensive experience in all aspects of eye care. He's a clinical director of a center where glaucoma and keratoconus patients are referred by both optometrists and ophthalmologists. And as he was talking, in his spare time, he's executive director and producer of Scary Night Productions, where he makes horror movies. I think pretty clearly, if you look at this, writing a book, doing practices, movies, Deepak Gupta is what we call a doer. He does things. He's done a lot of things in his career. He's achieved a lot. He's a fellow of the Optometric Glaucoma Society. Heck of a nice guy, good friend of ours, and in direct and indirect ways, and one can argue that he is responsible for Greg and I working together at this point. And that's a story for another live meeting. So with that, please, Deepak, take it away. I'm looking forward to hearing this.
Joe, thank you so much for that wonderful introduction. Thank you both, Greg and Joe, for letting me share as being part of your company. You guys have done an amazing job with all these meetings you've put on. I've been watching you guys throughout the years, just watching your company grow. And to me, that's just a sign of what an amazing job you're doing and with the quality of CE you guys are putting out. So I really appreciate the audience sharing an evening with me and you guys allowing me to be a part of this. So thank you. So for the next hour and 40 minutes, we're going to talk about anterior seg disease, and I call this conditions where every optometrist should be managing. As Joe said, I am clinical director for what started out as an optometric glaucoma and keratoconus center. It started that about 3 years ago up here in Rochester. And, glaucoma and keratoconus are probably the two things I'm most passionate about. Been doing both for over 26 years. And little by little, what happened to this referral center is I started getting more and more referrals from more than just glaucoma and keratoconus. So it eventually just progressed to, basically anything an optometrist wanted to refer to another optometrist for. And, I like co-managing with these guys. You don't have to worry about me stealing their patient. I would do the disease and send him back. It's gotten to be a nice synergistic relationship. And although I'm happy to do it, when Joe and Greg asked me to do this and they said, pick a topic, I said, let's pick up some topics that I get referrals from that I'm happy to take care of. But they're relatively easy things and maybe some optometrists could fine tune their skills and they can do it on their own. So that's what we're going to talk about tonight. And just to get the paperwork out of the way, I don't have any financial disclosures. I don't get paid by a pharmaceutical company, contact lens company, not a consultant. So whatever you're going to see here is the way I see patients in my practice, good or bad, it's the way I do things. And that's what we're going to spend the evening on. And my premise behind this course was twofold. Number one, optometrists long before me, fought the battle to progress optometry to where it is now. They fought these battles to get us diagnostics, then to get us therapeutics. Now the battle is to get us surgical privileges. And to me, I want to take advantage of that. I want to practice to the full scope of what I'm allowed to practice in my state. We know that varies from state and state, but I think it's an honor to all the people that have fought those battles to get us to where optometry is now. And secondly, I want to make as much money as I can. Like many of you, I enjoy seeing patients. We spent hundreds of thousands of dollars in 4 years of our lives, ultimately so we can get a good return on our investment. And I figured out, I've been in private practice since I got out of optometry school in '99. So to me, my income's always been directly related to how many patients I see and, my collections. So to me, the best way to do that is do everything I possibly can, take good care of my patients, and then the numbers follow where they may. So we're going to start our conversation. The first thing we're going to start with is corneal foreign bodies. And this is how I can always tell when there's a new grad that moves into the area, because I'll always get these things, and an optometrist, for whatever reason, will look at foreign bodies and say, oh, no, I don't want to mess with this. And to me, corneal foreign bodies really aren't that complicated. So I thought let's review and discuss together, how we can manage these things. And to me, we'll start with step one. When you get a patient who presents with a corneal foreign body, what's the most important thing you can do? A lot of optometrists say, well, obviously, you've got to get the foreign body out. Well, I think before you get the foreign body out, you want to take a couple of extra steps just to make that you're covered. To me, the most important thing you want to do is rule out ocular penetration. Once you do that, then you'll find out, handling a corneal foreign body isn't really too bad. When you look at the numbers, what percentage of corneal foreign bodies are penetrating? To me, like I said, I've been practicing 26 years, done tons of corneal foreign bodies. It's kind of surprised. You look up the numbers, I saw the research, most studies showed it's about 10 to 12% of foreign bodies are considered to be penetrating. I find in my practice that number's a lot lower, maybe 3, 4, 5%. I don't find a lot of them to be penetrating, but even then, that's always the first step. So the next question becomes well, how do you rule out ocular penetration? And to me, there's three basic ways you're going to rule it out. One is just by history. What does a patient come in complaining of? How did they get this corneal foreign body? Probably 80, 90% of the time, that in itself is going to give you a good idea whether you think this corneal foreign body is more superficial or more likely to be penetrating. Number two, you're going to do your slit lip exam. And this is something you're going to do anyway. But in my practice, 100% of the times on any corneal foreign body, I'll always document a negative Seidel sign. Why? Just because I want to show somebody that I did look for a penetration. I didn't see any signs of it. So I'll always perform that and I'll always document it. And lastly, if you're still not sure, dilate the patient. We don't usually associate dilation with superficial injuries, but if you're worried about a foreign body, just another level you can do, dilate the patient, take a look to see if you see any signs of ocular penetration. If you can't, what happens if, I said, like in my practice, I said less than 5% are penetrating injuries. What happens to some of those patients that if you can't rule out ocular penetration? To me, that's very simple. It's far and few between. You put a shield on that patient's eye, and you'll send that patient either to an urgent care or to an ophthalmologist if you're co-managing with somebody. And to me, once an injury gets to be penetrating, I don't usually deal with that in my practice. Once you do rule out penetration, which I said to me is about 95% of the time, then your job at that point becomes to remove the foreign body. Once you do that, it depends on, the nature of the foreign body. Sometimes it could be as simple as using a Q-tip or a cotton swab. You can use a foreign body spud. I like using a number 10, number 11 blade. I like using a 25 gauge needle, right? Sometimes with these injuries, sometimes it's easy. You put a drop of anesthetic in, you can get behind the foreign body with a little needle and just flick it forward. And a lot of times, once you rule out penetration, it's not all that complicated to remove a foreign body. Of course, once you do, what you're left with is an abrasion. And we all know how to treat a corneal abrasion. That's easy, right? Because whatever foreign body penetrated through the corneal epithelium, now you have to make sure that the epithelium heals back over. So once you do that, you can have your own protocol. This is my protocol for most, just your standard corneal foreign bodies. I love topical antibiotic drops during the day, at least 4 times a day. I like an ointment at bedtime, an erythromycin or a bacitracin ointment to get a little more broad spectrum coverage and to get some overnight lubrication into that eye. Depending on the patient's level of discomfort, I like the cyclopage patients. I find that makes them more comfortable than anything else you're going to do. And if your patient is you're still worried about it, you can always do a bandaged contact lens. And that's my standard protocol. Your protocol might be a little bit different, but I think once you remove the foreign body, your job is to get the epithelium to heal. When does the patient come back? Some of it depends on how big the foreign body was and the abrasion was. If it's a large abrasion, 5 to 7 days, a little less than a week. It's a small abrasion. If it's a larger one, sooner, 24 hours, 48 hours. Your job is just to make sure that the patient is headed in the right direction. And I think, when I see up in my area in particular, I see a lot of optometrists don't typically see some of these patients back for follow-up. And to me, you always have to see them back for follow-up for 2 reasons. Not only for abrasions, in my practice, anytime I write a prescription for a patient, I always recommend that the patient come back for follow-up. Why? Number one, you want to make sure that you've actually taken care of the patient's problem. Number two, if they're not better, then you want to find an alternative management plan to see how you can make a patient better. I never base my practice just on the assumption that a patient got better. I always like to document that a patient got better, and if they didn't, then what else we need to do to take the next level. If you had a patient with a metallic foreign body, a lot of times the patient will get a rust ring. I'll get optometrists that'll say, well, what did I do wrong? You didn't do anything wrong. A lot of patients who have a metallic foreign body, especially depending on how long that foreign body was in that patient's eye, are going to get a rust ring even when you 100% remove that metallic foreign body. Then the question becomes is what do you do about it? How much of the rust ring do you have to remove? And your options are do you remove none of it, do you remove all of it, or do you remove somewhere in between? And to me, I think there's no right answer on this. It depends on who you ask. To me, my general rule is I don't necessarily feel like you need to get all of it. And sometimes you're not even going to be close to getting all of it in one visit, but it doesn't have to be in one visit. So my general rule is if I can get 80% of it in one visit or in two visits, to me, that's generally enough. I'll get everything I can the first time, send that patient home, typically on antibiotic drops at that point, and give that patient time that some of those superficial rust things will come up to more superficial when you see him back for follow-up. Then you can do the same thing again. Once I've gotten 80, 90% of it, I'm reasonably comfortable saying that's going to be enough. You have an allergy brush, makes your life a whole lot easier. The chief advantage is you don't have to have one. Sometimes you can use other things. An allergy brush is going to make it so much less likely that you perforate through Bowman's membrane. So theoretically, it's going to make it so much less likely that you induce any corneal scarring. And for those people who say you don't have to, I think you do have to. Particularly some of these 60, 70, 80-year-old patients who have had this metallic foreign body and they get a rust ring. They've already been to your office one time, two times, maybe three times. And then they see the little spot in their eye and they say you don't need to remove it. You do have to remove it. Long term, when you have that rust ring, which is left unattended, you run the risk of corneal neovascularization or corneal pannus. So it's not just a cosmetic issue, that rust ring. Long term, that's going to become an ocular health issue. So my recommendation is always to try to get, 80, 90% of it out instead of just letting it all sit there, unsupervised. Billing for this thing, like I said, I've been in private practice. So in all this stuff, at the end of the day, I want to take great care of my patient. I want to find a way to bill it. And none of this stuff we talk about is going to be billed to vision plans. I'm not an IMED, VSP, Davis Vision, any of that stuff. I've never accepted any of those things in my practices. To me, when I first got out of optometry school, I was in an ophthalmology practice for the first 10 years before I opened my own practice. And 100% of what we did was always billed to medical. So that's what I've always done in my practice now. So here are two different CPT codes for corneal and foreign body removal, depending on whether you do it under a slit lamp or without. You can see the numbers there, 65222, 65220. Average reimbursement, depending on the insurance and the region, some variability, obviously, $140 to $150. To me, that's not bad. Corneal and foreign bodies don't take all that much time to remove, and that's only counting the initial removal. And you're still going to see that patient back for follow-up. To me, it's so much better than doing a 30, 40-minute IMED exam when you can practice to full scope and your reimbursement is so much higher. I think that brings us to our first polling question.
Fantastic that launch, Joe. If you can check the see if there's any questions that have rolled. And I'm just going to make a little echo what you said there, Deepak, regarding the billing is that, there's no 90-day, 10-day period. So you're able to bill those follow-up visits as the code whenever they come back. So.
And correct me if I'm wrong, Deepak, but there's also a code for application of a bandaged contact lens.
There
if
is.
That's what you use. Now, Audrey asked, what do you use for a cycloplegic? Home atropine is really not available. That home atropine was a great drug, no longer really available to us. What do you like?
I personally would just do a cyclogel. If I'm going to see the patient back 24 hours, I don't even prescribe it. I'll just put a drop while they're in their office and send the patient home. If I'm going to see him back 3 or 4 days later, then I'll actually write a prescription for it. yeah, the patient's got to take it 2 or 3 times a day, but usually that's not a problem.
Now, while the things are coming in, Deepak, I'm going to share. I'd like to share a couple of pearls
Hmm.
because you talked a lot about penetration. I do a lot of expert witness and medical malpractice, and I've dealt with a number of these things. And what I want to let the audience know is anything high speed, you've got to have a strong suspicion that it was penetrating. And these things can self-seal. You may not have a positive Seidel. And it's important, as you said, Deepak, to write down, Seidel negative, because just putting fluorescein in the eye does not, quote unquote, count as a Seidel test in the eyes of the law. So you write down Seidel negative. It shows a level of sophistication that is very important should anything go awry. So everything you said was great about that. Just be aware that they can self-seal. You may not know. One of my former residents had a penetrating injury, and he referred it out to a corneal specialist, and the corneal specialist said very nicely, like, "You were wrong. It's just a corneal abrasion." But he had actually filmed and uploaded to YouTube the positive Seidel's test. He shared the link with her, and she said, "Yep, you're right. It's penetrating. Thank you very much."
All right, so the polling question is rolling in here nicely. People are paying attention here. I'll display the answer, and it has 90% rule out ocular penetrating. Before action was 0%. Check IOP 2%, and we had 7% saying check vision. So I agree. Check and make sure you rule out penetrating the foreign body. All the other things are important, but I won't be down if it's penetrated. As Joe said, it would be self-sealing.
Cool.
Very good.
Move on. We're waiting for more questions.
No,
Joe, we cut up.
Hold on 1 second. Let me go back to the chat. We're good.
Okay.
Right. So we're going to move on from corneal foreign bodies now, and we're going to move over to dry eye disease. And I know we talk a lot about dry eye disease, and I think optometrists, we sometimes underestimate, how much of a therapeutic practice we can have, even just exclusively on dry eye disease. It's by far the most common medical and ocular condition we see in our patients. And when you look at the numbers, it's estimated that 12 to 20 million people in this country have dry eye disease. And I'm sure that number is just grossly underestimated. When you think of the number of our patients who self-medicate with over-the-counter artificial tears, and so a lot of these patients are just ones who don't come up with an official diagnosis of dry eyes, even though that's what they're suffering from. So even that 20 million people, as large as that number is, I think it's probably more than that. We're talking about the artificial over-the-counter market being $3 billion a year. So, there's a whole lot of people out there that are using these things. And so the question for us is, I'm not going to talk so much about diagnosing dry eyes. I think there's a whole litany of tests you can do to diagnose dry eyes. I think the average optometrist, at least from what I've seen in clinical and private practice, diagnosing dry eyes is usually a history and a slit lamp. Maybe if you're lucky, you do a TBA, you do a fluorescein, you do some staining. And that's primarily what 60-70% of optometrists use to diagnose. And certainly there's other tools you can do if you want to get more sophisticated. When you get past that, I want to get past into the more of the management stage. Patients that are self-medicating, that are under control is great. But there's a lot of people that use over-the-counter artificial tears but still need more help. So what are we going to do? And this is by no means an exhaustive list of what you can do, but some of the more common things that I do in my practice and what's out there for patients who aren't getting enough relief with just over-the-counter artificial tears. I'll start with punctal plugs. I'm a huge fan of punctal plugs. I think there's very little downside to it. Conceptually, punctal plugs is great. If you've got a patient who's not producing enough tears or they're draining out too quickly, let's take this piece of silicone, let's cover the puncta where the tears drain out of. That way, whatever tears your patient is producing are going to stay in the eye longer. When you start talking about using punctal plugs, 3 basic types. Your temporary or your self-dissolving collagen plugs typically last about 5 to 7 days. In most cases, if you're going to use those, you're going to use them as diagnostic. I don't really do that anymore, but if that's something that's important to you, if you want to see how well you think your patient will respond, you can do that. And one of the reasons why I don't do anymore is logistics. So these collagen self-dissolving plugs generally only last 5 to 7 days, best case scenario. The problem is with most insurances, if you install these collagen plugs and you bill them for it, which you're allowed to, you can't have the patient come back before 10 days before you can instill more permanent plugs. And the problem is if these things dissolved after 3 or 4 days, then by the time you see your patient back on day 10 or day 11 and you ask them how they did, they're going to say they didn't do well because they're not necessarily going to remember that for the first 2 or 3 days they were doing better and now they're not. Then it makes it a little bit harder to say, let's instill some permanent plugs. Some optometrists like semi-permanent plugs. These things are designed to self-dissolve after 3 months or 6 months. I prefer the permanent ones. To me, if I'm going to plug a patient, I like to plug a patient. I'm reasonably sure the patient's going to do well. So I've been doing plugs for 20, 25 years, rarely have a complication with them. It is possible, but I haven't had too many problems with them. So I'm pretty sure when I want to plug a patient, I'm going to do it. And the way I do plugs, if you have a patient with moderate or severe dry eyes, there's some studies show that you worry about cytokines which are already present. And if you do plugs, you're going to keep those cytokines in the eye a little bit longer. I don't really have that issue too much. If I'm really worried about it, I'll go ahead and RX and Alrex or Lotemax prior to doing plugs or in addition to doing plugs that help quiet that eye down a little bit. Like I said, I don't really do collagen plugs as diagnostic anymore. I like punctal that have fallen out. There's a lot of different brands out there in terms of punctal plugs. Some optometrists will do intracanalicular, which is great. I like the old-fashioned T-shaped plugs. Why? To me, clinically, it makes sense. You're going to instill this plug, and I'll teach patients that, if they ever wake up one day and their eyes are irritated or their dryness is getting worse, they can just pull their lid down, look in the mirror, and they should be able to see that tiny little white dot. And that'll let them know whether the plug has fallen out or if they're just having some other issues with dryness. And obviously, when that patient comes back into your office, it changes. If the plug's fallen out, then that's a very easy fix. You can go ahead and put another plug in. If that plug is still there, then you need to look for other management options. To me, intracanalicular, when you've already pushed that plug down, you don't see it clinically anymore. So when that patient comes back, let's say a month later, and they say they're bothered with their dryness again, you're not really sure if the plug went flushed all the way through or if there's some other issue that the patient's having. If you're doing these things, I'm very spoiled. I like these sterile preloaded punctal plugs. Several different brands out there. There's Tear Savers, there's Odyssey, Parasol. They all have the same basic setup. You've got the plug here, which is at the tip. Usually on the back end of this, it almost looks like a little pencil point. There's a little dilator. You can put a drop of anesthetic in that patient's eye. Use that dilator to open the puncta up a little bit. Have the patient look up. Take that puncta, just put it right over the punctal opening. Go ahead and push it down. Once you've done that, you hit the little button, which is right on the side. That releases the puncta. And have the patient look up, and now you're going to see that little tiny white circle that's over the puncta. That'll let you know how well that plug is seated. And really, that whole procedure can take a minute, 2 minutes tops. It's not a very complicated or long procedure. You can have a couple different ways you can do it. You can do it behind the slit lamp, which is usually what I do. Some of these patients, you don't even need a slit lamp. You can just do it outside the slit lamp, or some optometrists will use loupes instead. Either way, as long as you can visualize the puncta, it's a very short and quick and easy procedure. Billing on this is very straightforward. CPT code 68761. I put E2 and E4. I rarely occlude the upper puncta. There are some studies that show some tears do drain out of there. I haven't had very much clinical success, occluding the upper puncta. I don't think it makes a difference in a lot of the patients I've done. So E2 and E4 are your lower two puncta. Most of the times when I'm going to do this, I'm going to do both. I'm going to do them on the same day. Documentation for most insurances is not all that complicated. You're just going to document that the patient's not getting sufficient relief with prior treatments, whatever that was. You do that. Reimbursement, once again, varies with insurance, varies with regions. Roughly $180 for one eye. If you're going to do both eyes, you do take a 50% hit on doing multiple procedures the same day. But to me, that's still $270 for something that's going to take 5 or 10 minutes, and all of which was going to help your patients. So I put this on here, the downside of doing plugs, and I'm being very sarcastic when I say the downside to doing plugs. What I love about punctal plugs, which is to me, it's my go-to thing after patients don't respond to artificial tears, is that patients will get better really quickly. You'll put plugs in today, by tomorrow, by the next day, most of them, if they're going to respond, will be able to say, hey, my eyes feel so much better. So I love that. And secondly, like I said, this is a nice revenue generator for your practice. It's reimbursement's high. Punctal plugs themselves, they are a little expensive, $40, $50, $60, $70 a pair, depending on what brand, what type you get. But it's still a relatively high profit ratio for something that you should be doing anyway, which is taking good care of your patient. It's another drug that came out recently. I don't have a whole lot of personal experience with it.
Hey,
It is
Deepak, let me make a comment on your plugs here.
sure.
And I'm gonna tell you, when I looked at your slides last night, during the talk here, but we got doing other things. The I and the E, I did the same thing for it's MIEBO for MIBO. But I don't know why they did that, but that's what they did. Anyway, I'm gonna go back to to my comment was. The only time I found out plugging all four is I work right down the road from a I don't know, it rotates 8-woman man rheumatology practice, and I get a lot of Sjogren's, rheumatoid arthritis, mixed connective tissue disease, because they send a lot over. A lot of them are on plaque, following in for their plaque toxicity. My clinical pearl after telling that is that the only time I plug all four is in the Sjogren patient. I found that really helps out. So that's the only time I really become Pavlovian in a sense, is plugging all fours if they have firm diagnosis from the rheumatologist of Sjogren's, they're staining, and I put plugs in. I do all four with the warning they might tear and be back within a week for me to pull out, but that's 10% or 20% of the time. 80% 90 success. So 2 cents on the punctal plugs in all four.
Yeah, Deepak, in our practice, we have 2 corneal specialists, and they will actually frequently do the upper plugs. When I say upper plug, maybe 25% of the time. Now, a couple of questions came in. Do you dilate the punctum before you put one in?
Yes, 100% of the time. I don't always
Mhm.
dilate a lot, but I've got the preloaded ones, which got a built-in dilator anyway. I put a drop of anesthetic in, I'll pop the dilator down, spin it, just get it open a little bit, just makes it a little easier to pop the plug
Mhm.
in.
Now, not claiming superiority or inferiority. Do you have a plug that you prefer?
I use the Parasol a lot just because it's preloaded. It's cheaper. I used to use the Tear Savers by Vision, and they're good quality plugs also, but they're just a little bit more expensive.
Mm-hmm.
That being said, like if you don't want it preloaded, you can get a lot of these that are not preloaded, so you can load them yourself. I just found myself fumbling around trying to load it and spending more time than I needed to. These things come in sterile packages, so it's nice. You just rip it open. It's nice and sterile. It's got a little quality control on there. You can put into a patient's chart if you want to keep, control of track of, whatever, if there's a recall or anything.
Mm-hmm. And another question just rolled in. What's the best way to gauge the size needed?
I don't measure it. I think there's devices out there that you can pop a little thing in and measure. If when you do it long enough, I basically just look at a patient's puncta, small, medium, or large. I'm going to use like a 0.5 or 0.6. Probably for my mediums, and then these punctal plugs will go anywhere from a 0.3 to a 0.8 or a 0.9. So 0.5, 0.6 is going to take care of probably half my patients. Patients got a really tiny puncta, then you can go a little smaller, 0.3, 0.4. If we got a large one, so I kind of just eyeball it, and after a while, that's all you need to do. But if you're looking
Greg,
to actually measure, there's a little device you can use to measure it.
what do you do, Greg?
Yeah, I agree. I mean, I put a ton of these in. It's more pull it down, take a look, and just eyeball, if you want to say. Most of the time, you're putting in medium. Another clinical pearl would, if you're too small, and you put a medium in, and the patient still has a lot of elastin and collagen, it actually can pop it out, can make it uncomfortable, and also can pop out the plug altogether. Obviously, if the puncta is too big and you put too small in, it's going to fall out. So this discussion of having the right size in the puncta is critical. But I would say probably, when I have them order them in, and we order in, 6 or 8 at a time, because again, I have this rheumatology practice right down the road. I'm using plugs. The majority of them are medium. I keep a larger and a small, but it's more of an eyeball. You pull it down, make sure you're not distorting it. Pull the lid down, take a look, and it's usually about a medium.
And actually, there's a new occluder called Lacrophil. I'm not sure if either of you have used it. You use a cannula and a viscoelastic that you put into the lower puncta, squeeze it through, and it'll go all the way through to the upper puncta and clog both.
Sure.
We have it in our practice. I have not done it. My wife has been doing it. I've not done it. It is pricey. I think to get it, it's $100. I think it's $100 for the hyaluronic acid or the viscoelastic that you're putting in there. So it is costly. I'm told, I believe, the oculoplastic surgeon in our practice invented it or was involved in its development. I just have to verify if that's actually true or not.
It's a nice concept. I like that. Hey, Joe, you're
Yeah,
in an
I
ophthalmology.
was just meeting with Todd Love and the whole crew. They went from Alcon to Sight Sciences to now this Lacrophil. Meet with them down at Vision Expo East. We started a conversation, then we got interrupted. So hopefully I'll see them at 6 weeks. So get more information on that. But Deepak, please take your MyBell.
Question, Joe, you're in an ophthalmology practice. We've got some MDs up here who are actually cauterizing the lower puncta. I don't know if you have that down there as much.
They're not.
That was kind of weird. Like, why wouldn't you at least do plugs first? But a lot of them, when some of their elderly patients come in, instead of doing plugs, they'll just cauterize and be done.
Yeah, no, our group does not do that.
Yeah, but the only time I would see that to be beneficial would be kind of that rheumatologic patient. There was an ophthalmologist in my area doing it, and I had to send it to the oculoplastics to have them open them back up because it was too much. So they had to go in and, luckily, I mean, to cauterize it, just so everyone knows, what they do is they numb the eye, lidocaine, they dilate the puncta. They literally stick the cauterizer in while it's cold, hit the button, it heats up, and then basically they pull out, and you just hear it, you smell it and hear it all at the same time. I've seen it done, obviously. Same thing, you need a cold one for the other one. Dilate it, you stick it in, they're all numbed up. You hit the button, you hear it kind of crackle and sear, and then you pull it out, and it scars closed. So, but sometimes it has to be reversed.
Hey, Deepak, I'm going to roll 2 real quick questions together.
Sure.
For billing purposes, do you have to try temporary plugs and document failure with artificial tears first for billing purposes? And do you plug Bell's palsy patients?
So for the first one, you don't have to do temporary plugs as diagnostics. But anytime I go and do any of this stuff, whether you're writing a prescription or doing plugs, I will always document that a patient is not getting sufficient relief with artificial tears. I've never had a problem doing that. And in terms of Bell's palsy patient, I will do plugs in. A lot of those patients, if the Bell's palsy resolves, you end up pulling them out sometimes, but I don't find any downside to doing that. But you're still going to have to do like some of the ointments at bedtime and stuff, because a lot of them are going to have some lagged ophthalmos at nighttime.
You're good. Let's talk MyBell.
Good. So I don't have a whole lot of clinical experience with MyBell, but I thought I'd throw it in there just for completeness. New prescription product 4 times a day, and it's specifically designed for evaporative dry eyes. So assuming that you've confirmed that your patient is having problems with that, it is a possibility that's out there. In our area, I don't do a whole lot with this anyway. It just costs prohibitive. It's like almost every new product that comes out, it's running about upwards of $200, $300 in our area. So even if you want to write a prescription for it, a lot of patients come back and say just not cost effective to do. I don't know if you or either one of you have had any experience with this in terms of how well it actually works and things like that.
Yeah. So the keys that it works the best in would be your commercial patient right now. Your Medicare, Medicaid patients, or what you're federally subsidized, are going to be a little bit more of a work, a little bit harder. The commercial patient, B&L is able to pay down, help keeping the cost even after that second prescription. It's a much smaller drug. My pearls would be you have to be careful. It's 10 or 11 microliters. Most drops are 30 to 60 meters. It's 100% drop. So there's preservative, which is another positive, but there's no water, so it doesn't sting. So it's a super small drop. And the patient doesn't feel it go in there. And it, as you have there, it works on the vapor disease. They have down QID. Obviously, if the rep comes in, they cannot talk off label because it says QID for dry eye disease signs and symptoms. But obviously, I can have the patient, when I prescribe it, use it up to QI. I really like it. It works well, but you are a little bit of work sometimes to get it, and then it help with that evaporative disease, which they like to promote that it's 80-some%. It's the majority of our eyes evaporative or meibomian gland dysfunction, so it kind of helps that patient.
Cool. Good. And we're going to move on from MIBO, and we're going to talk about this. And when you talk about this next session, and I'm going to lump in Restasis, Hydra, Cequa, all these cyclosporin agents. Just remember my financial disclosures when I talk about this. Well, the way I'll talk about Restasis and these things is probably a little bit different than when you've heard from some other people. So, number one, Restasis, as you remember, when it was FDA approved, it's based on this concept that patients with moderate to severe dry eyes have inflammation of the lacrimal gland. So Restasis is this immunosuppressive agent that says, hey, if we can control the inflammation of the lacrimal gland, we can restore the natural function of the lacrimal gland. If we do that, then it will start producing tears on its own. Xiidra, a little different mechanism of action. It inhibits T cell activation. Still the same basic concept. Let's restore the natural function of the lacrimal gland. If we do that, tears will start getting produced on their own. Cequa, just another reformulation of the cyclosporin, 9% and 0.7, such as Restasis. And to me, I've been to plenty of lectures, and you hear some of the big known speakers out there about most common reason for failure. And I've heard just about every explanation out there when optometrists ask, one of these guys, what if, how do you know if it's working for my patient? And the answers I always hear is, well, if it's not working, Restasis takes 6, 8, 10, 12 weeks to work on many patients, that they're probably being non-compliant. Or sometimes you hear that, they're just a slow responder. So if it didn't work in 3 months, try it for 6. And of course, the way around this was always, well, write a prescription for Olotemax at the same time, wait for the first 2-3 months, and then take a patient off the Olotemax, and then hopefully the Restasis or the Xiidra is working. But if you do a little science and you do a little research and you find out, to me, what's the most common reason, I should have put this as a poll question, I didn't, for failure for Restasis. And I think a lot of optometrists are shocked when they realize if you look up the prescribing information for Restasis, so what they used to finally get FDA approval in the clinical studies, that it only works 15 to 17% of the time. So to me, I found it amazing. We're talking about a drug which is $2 to $3 billion a year, that it, in the trials what they submitted to the FDA, 15% of people demonstrated improvement with Restasis compared to 8% with placebo. So it's not a whole lot of difference. And that doesn't necessarily mean it doesn't have a place in the dry eye practice, because of course it does. But just realize that when you prescribe it for your patients, and Greg and Joe, I'm sure you guys have been involved in clinical studies. I think the average optometrist doesn't know how regimented clinical studies are. So if you're talking about doing, FDA trials for these drugs, you're talking about confirming a case of dry eyes. You're talking about making sure patients are 100% compliant with the BID dosing. They're following the exact protocols, coming back in the exact visits. Problem is, you don't even get that level of compliance in the real world. But even in that strict setting, if it only worked 15% of the time, think about how many times it's going to work out in the real world. So like I said, it doesn't mean it's not a place in the practice, but realize 4 out of 5 people are going to fail not because they're not being non-compliant or any other reason, just because the drug only works in roughly 4 out of 5 people. I mean, 1 out of 5 people. And to me, like I said, hasn't stopped its market share, right? $2 to $3 billion a year for this drug. And when I say it's 15% clinical success rate, realize that it failed the FDA approval the first time. Also realize that Restasis isn't available in many other countries. Most countries decided if a drug only works 15% of the time versus 8% versus a placebo, it's probably a drug that's not worth being out there. So, like I said, just take that with 2 grains of salt. I'm not trying to bash Restasis or Xiidra or any of these drugs. Just realize, where the science is and how often it's actually going to work. And still worth a shot. I mean, I still prescribe it sometimes if you don't have some other options or other options haven't worked. But just go in with your eyes open, saying that if it fails, it's not necessarily anybody's fault. Just the nature of the way this drug works.
So let me chat on cyclosporin just for the fact of, one, it's a fat loving molecule and it's hard to get the molecule. When you get it to the tissue, it works. I think the other points, if you look at what Sequel has done and what Vive has done, what they've done is they've increased the concentration. It went from Sequel went from 0.5, almost doubled it to 0.9, and then Vive has gone to 0.1. So they've increased the concentration, get this fat-loving molecule to the tissues to help out. But what they also did with Sun and Vive is they changed the delivery system in order to help get it through that protection, to help get it through that protective watery layer that's out there. So no surprise, 1 in 5. When I used to prescribe, I would tell them to use the whole thing, 4 drops a day. Try to force it in. Try to work around the I guess the shortness of the cyclosporin being fat loving that's out there. It also highlights that it goes after T cell activation, right? Not everyone probably had cell activation. So it just goes down to when we say dry is multifactorial, is that it's probably not all T cell activation. Then on top of it, the shortcomings of getting the medication there. So no surprise. And then on top of it, like you said, Deepak, that was a great. In those clinical studies, they made sure they were taking it twice. Our patients probably don't take it twice a day. So I was never a huge prescriber. I was never on their speakers bureau, so on and so forth. But some of these new medications have a little bit more promise with those higher concentrations.
And before we go on, because we're still pretty close to the MIBO talk, how do you confirm dry eye, evaporative dry eye? What's the best way to do that? Because that's one of the questions that came in.
I do quick and simple. I just do a quick T-bot. I don't do a whole lot of other stuff just to confirm it.
Yeah, I think you boiled it down pretty simple there. Throw some fluorescein in, see if that's breaking up quickly, see if there's an evaporative. I mean, you can then try to express the meibomian gland. You can do some imaging on it, but I think simple as they say, and just use a T-bot.
Good.
Yeah,
And I think then we'll continue with other options. I love Lodomax and dry eyes. I said, even though we call this a site-specific steroid, a softer steroid, I still don't use it long-term in most patients. I don't really see the benefit of it. To me, what I use it for is what we call short-term pulse therapy. You get a patient on whatever chronic management you have for dry eyes, whether it's tears, plugs, whatever, and these patients are doing well. Inevitably, at some point, they come in and say, hey, I was doing great, and then last week my eyes have really been bothering me. To me, that's a great prescription. You write a prescription for the Lodomax twice a day. They use it for a week, 2 weeks. You get them over that hump. You get them, past that little flare up, and then you take them off the Lodomax and you just stick them back on whatever chronic regimen you have it on, and that seems to work pretty well. Other things you can do, there's a whole litany of stuff you can do. We know there's been a lot of research showing nutrition and omega-3s. That tends to help a lot of people with dry eyes. I like some of these non-pharmacological agents. To me, one of the most success I've had is with humidifiers. Telling patients to go to Walmart, Target, whatever, buy a humidifier, put it in their bedroom, figuring that's the one room in their house that they're going to spend, 6, 7, 8 hours, depending on how long they sleep. So it helps with that evaporation. And secondly, with the warm compresses, even patients who don't demonstrate any level of meibomian gland dysfunction, just have them do a warm compress when they're in the shower every morning. You get a lot of people with dry eyes who will say that actually helps as much as some of the other stuff you're going to do. Notice I didn't put something on like IPL on there. I don't have any experience with that. I know a lot of doctors have done well doing IPL and stuff like that for dry eyes. But to me, I kept a lot of this stuff simple with dryness and just relative to what I do in my practice. That being said, so we'll talk a little bit about contact lenses and dryness. And this is, like I said, I do a ton of disease in my practice, but was done primary care also. And I think a lot of optometrists, I think they live a little blindfolded. They always say, "Oh no, not me, not me." Dryness isn't a practice for my contact lens patients. You look at just about every single study that's been done out there, has verified that discomfort due to dryness is the single most reason why people drop out of contact lenses. And to me, when you're trying to identify these patients, in terms of which one of your patients, your contact lens wearers, are having problems with dry eyes, the most important questions isn't how your contact lenses feel, are they dry, are they irritated? To me, when you're really trying to identify these patients, the most questions asked is average wear time. What time you put them in the morning, and what time do you take them out? And the way you identify these patients is, patients who say, look, I put them in the morning, and by the time I get home from work, my eyes are so bothering me that I have to take them out right away. A lot of patients don't complain about that because they just assume that's the way contact lenses feel. But we know from our experience that if a patient is really happy in their contact lenses, we have to talk to them about overwearing the contacts, not underwearing them. So patients that say that they've got to take them out as soon as they get home from work, that's usually a patient who's having some level of dryness or irritation. So, you can be a little proactive and start talking to your patient about contact lenses and dry eyes. And that's a nice way not only to build your therapeutic practice, it's a way to build your dry eye practice. You're going to do both. If you manage your dry eye practice, you're going to build your therapeutic practice there. You're also going to enhance your contact lens practice. You're going to keep your patients that are in contact lenses longer and keep them happier, which is ultimately our goal. And that we're going to come up to our next poll question. Just still back.
Let me get that launched here. And it is now open. Which of the following bodies would most likely result in a rust ring? Metallic, plastic, wood, or paper?
I think you're good on questions there, Deepak. We're doing well.
Thank you.
There was Joe answered yes to it, but you might be able, as this is rolling in, someone asked about an abnormal T, 10 seconds, 8 seconds. Most of the ones I see that are almost instantaneous or 1 or 2 seconds. I think 10 seconds is a good number. You start, 8 to 10 seconds is, they're pretty good out there. So my advice would be is someone, maybe a child or I don't know, year old, not on a device and all this other stuff, but throw some fluorescein in behind the slit lamp, when you're doing an exam, a comprehensive exam, and let healthy meibum and count it out, and then see how long it takes to break up. I mean, you can get into 20 some seconds at some point, and you can really see some of those abnormals.
Greg, I second that. I think that's probably the case for almost a lot of this stuff. We were talking about T-BOT, we were talking about, measuring puncta, we were talking about optic nerve head. If you just start getting a feeling you're doing this stuff on everybody, you'll get a feel for what's normal and what's average. Then you find out what's too high or too low.
And Deepak, they nailed this one. We got 100% saying metallic.
Oh, good.
That never happens.
That was like 20 slides ago, so that's even better. Should we move on to the next one?
Absolutely.
All right. So next topic I thought I'd talk about is recurrent corneal erosion. And it's something, I see up all the time up in my way. And it's just another way where we can build our therapeutic practice. We're talking about a condition here where the corneal epithelium has a hard time adhering to the basement membrane. And, many risk factors for RCE. We're talking about ocular trauma, which is usually the most common, particularly in patients with a history of corneal dystrophies, people with dry eyes, people with diabetes, people that have had corneal surgery. And I think the telltale sign for RCE, aside from your slit lamp exam, is a patient who has an abrasion, who typically is responding to treatment, and then for whatever reason they get another abrasion without any other event or trauma to explain the abrasion. Management short term is easy. Short term, we want to treat that corneal abrasion again. But long term, once we figure out that this isn't just a single isolated corneal abrasion, that it's actually a sign of recurrent corneal abrasion, we want to try to find out how to stop these episodes from happening. And here we'll go through a bunch of different management options. Once again, in no particular order. My favorite is at the top here is Mira 128. I'm a huge fan of Mira 128. I like drops during the day, breakfast, lunch, dinner, ointment at bedtime. And I find it's very easy. It's over the counter, and most patients can do that. And, typically I'll get some patients with REC that I don't keep them on Mira 128 indefinitely. No downside to doing that. But if you're talking about the minimum amount of time I recommend Mira 128 for RCE is about 2 months. It takes about 6 to 8 weeks for the corneal basement membrane to regenerate 100%. So to me, that's always the number I have in my head when I prescribe anything or I recommend anything, whether it's over the counter. It's I want to cover that 6 to 8 week time period. And I know in my head some people will get better sooner; they may not need it, but if you can cover that time, then you're reasonably sure that the patient's going to be fine. If you don't want to do a Mira 120, you can do a bandage contact lens. Very easy protocol. We don't have an extended wear lens that's approved for 2 months. That's still the window I'm trying to cover. Do a night and day. I'll do the 8-4 base curve to get a nice tight fit. Put it in on day 1. See that patient back at the end of the month. Stain that patient, make sure they look good. Pop that lens out, put another one in. See them back a month later. Once again, now you've covered that 2-month window, which is what I'm always trying to cover. You want to get more aggressive, you can send the patient out for this PTK, the therapeutic lasers procedure. The concept here is that if you can use this laser to smooth out the edges of that abrasion, patient's going to be less likely to have an episode of the RCE. Alternatively, you can use a bent 25 gauge needle to puncture through the epithelium to try to help that corneal epithelium adhere to Bowman's membrane. Obviously here, if you have a central abrasion, it's something you want to be careful about because this is going to potentially induce some tiny little scars. You want to prescribe, and you have orals in your state, doxycycline, 50 to 100 milligrams twice a day. What doxycycline does is it inhibits the enzyme, which is ultimately responsible for the breakdown of the corneal basement membrane. So if you inhibit that enzyme, then you're going to help that patient's RCE. If you're going to write this prescription, 3 basic things you want to at least take the time to educate your patient for. You all know about the sunlight exposure. You want to document. You want to tell your patient about that. Always recommend taking doxycycline with food. Will help with the GI issues. For your female patients, and this is something you always want to document. Doxycycline can interfere with birth control. So last thing you want to do is go home to your significant other and tell them that you're responsible for one of your patients getting pregnant. It doesn't usually lead to a really fun conversation. But those are at least the bare minimum of 3 things you want to educate your patient on. And once again, trying to cover that 6 to 8 week time period. I mean, the minimum amount of time I would have a patient on this would be about 2 months. You want to be simple. Just use a drop of anesthetic. Use a little pledgelet to smooth out the edges. You can do it manually if you don't want to have a patient sent out for a PTK procedure. Sometimes just smoothing out the edges of that abrasion are going to be enough to help that patient not have another episode of RCE. We'll talk about probably I wouldn't say the most invasive, is amniotic membranes. I've had a pretty good exposure to amniotic membranes when I was in my practice in Connecticut. We don't do a high volume of them 2 or 3 times a month, but it's pretty consistent. So let's talk about membranes, amniotic membranes for a minute. What is an amniotic membrane? It's basically avascular fetal tissue that was harvested during elective C-sections. Once it's harvested, it is obviously treated for screened for disease, treated with broad spectrum antibiotics. And amniotic membranes give you three things. Number one, they give you a physical barrier, kind of like a banded contact lens would. But amniotic membranes give you two additional benefits. They give you anti-inflammatory processes. They give you cell migration, and it helps inhibiting infections. Two basic types of amniotic membranes on the market. Your cryopreserved, as the name implies. Once it's harvested, it is stored frozen. And these are something, if you have in your office, this is what I've used most often, is the Procera brand of BioTissue. You actually store them frozen in your office. And what happens is when a patient walks in and you're going to need a membrane, you take it out of the freezer, leave it on the counter for about 20 minutes or so. And that's usually thawed enough that you can actually instill it into a patient's eye. Your dehydrated product, as the name implies, it's not frozen, it's preserved using a vacuum with a low temperature heat. So this isn't one that needs to be stored frozen. One of the most common dehydrated products on the market is your EmbioDisc. Installation. This is of the Procera Slim, which is what I've used the most often. This is the old one, the ring one, that recently just came out with, Procera just came out with a ringless version of this. This is the cryopreserved. Put a drop of anesthetic in a patient's eye, have the patient look down, tuck the superior edge of this ring under the superior lid. Then you have the patient look up, do the same thing for your lower lid. When you're done, that's what it looks like. I find most patients can tolerate it reasonably well. It's not exactly painful. It's not super comfortable. If your patient's having a problem with tolerability, usually you're only going to be doing this in one eye. You can always tape a patient's lid shut. I'll probably have to do that one out of maybe 10, 15 times. Most patients, they can tolerate the discomfort enough that you don't have to do that. Once you instill it, usually we'll follow up in about 4 to 6 days for removal. If you're going to prescribe antibiotics or steroids, you can instill that even with the membrane in, there's no problem. And the nice thing about it is, even though you're only keeping it in the patient's eye for 5, 6 days, patients will get some of these anti-inflammatory benefits, up to 4 to 6 weeks, even after that membrane is removed. The other type, like I said, there were two types of amniotic membrane, dehydrated. Only use this a handful of times. And you can see how it looks even totally different than the Procera lens. And the only problem I had with it, which is probably easy to fix, they do decenter sometimes. Otherwise, you use it the same exact way. That's a pretty easy fix. You apply the dehydrated membrane, you put an extended wear soft contact lens over it. The night and day and the 8-4 base curve works really well, and that'll cure the centration problem. The chief advantage to me of the dehydrated is two things. Number one, you don't have to store it frozen, so you can use it right away. Number two, in terms of a practice management standpoint, it's so much cheaper to use the dehydrated product than it is the cryopreserved. Procera is a nice, wonderful product, but it is a little expensive to buy. Clinical uses, I use it for RCE, I use it for chemical burns, use it a lot for non-healing corneal ulcers and abrasions. When you read some of the literature out there about amniotic, they talk about using it for severe dry eye disease. I don't really use it for dry eye disease. Theoretically, it's possible. I know a lot of ODs that do. I just personally don't do that. So again, billing, CPT code 65778, placement of amniotic membranes on ocular surface without sutures. And in most states, this is something that is within the scope of practice, what we're allowed to do. And so these membranes, depending on how much what quantity you buy them in, what brand you buy, anywhere from 400 to 800, reimbursement anywhere from 1,000 to 1,500, depending on region, depending on insurance, on what insurance. I think that will take us to our next poll question. Greg, I know you do a lot with membranes, right? And
I do a lot with membranes. My favorite to go to is you covered is cryopreserved. There's a few more, the biologics. When you actually look FDA, the dehydrated ring versus wound healing. You got to be a little bit careful with some of the dehydrated. with an infectious keratitis. It will say on the package insert that it's contraindicated in dehydrated, but actually indicated in cryopreserved. You know, a lot of the times the marketing hype is that they're underable. I agree with you. You know, they're not the most comfortable thing, but when someone has a sick eye, the you know, they don't mind it if this is going to help. This is going to help. Very high success rate by using a cryopreserved amniotic membrane and slowing down or stopping recurrent corneal erosion. So.
And while the answers are coming in, Deepak, one clinical pearl that I want to share, because I've dealt with this with students, residents, graduate practitioners, and unfortunately in malpractice cases. When you hear the phrase pain upon awakening, the first thing people, I mean, what everybody goes through is recurrent corneal erosion. But the question is, when you woke up, do you have immediate pain? That is recurrent corneal erosion. Did the pain wake you up? That's a corneal infection. There's that difference, and that's very important to ferret that out. So not all pain upon awakening is recurrent corneal erosion. If the pain was such that it woke them up, they've had a closed eye, they've been harboring bacteria that's now been growing, and it wakes them up with pain. So there is a difference. Don't undertreat RCE, or I should say, don't undertreat a true corneal infection, thinking it may only be RCE.
All right, and we have a results. We have 99% going with your patient will typically respond quickly.
Cool.
So as long as we're caught up with questions, I'd say you move along. The one that I want to make when you're talking about bandage contact lenses, I always say this every time we talk about I have to go to write it up. I've never seen it in the literature. One of the things I like to do is what I call a nocturnal bandage contact lens. I like that 2-month period, that 3-month period, but I don't contact lens being on there. So I take that night and day, like you said, and I have my contact lens staff and technician train them to put it in at night, wear it while they sleep, get up in the morning, kind of start their day, kind of a reverse. Take out the contact lens, put it in the solution because they're usually not going to tear open. But I like your thought of leaving it on there to mitigate any type of trauma to that cornea. But I've had people that don't want to go for PTK, and I have 2 or 3 years wearing a nocturnal bandage contact lens. So maybe I'll have Joe help me out, write that up some article. I've never seen it, but I know I've had people reply after I told them and say, hey, pretty good.
No, I love that. I'd never heard that before either, but that's to try that protocol. Your goal is just to have that lens overnight when they first wake up, when they're going to more likely abrade that cornea, just have that contact lens cover it, and then once the cornea edema resolves after that first half hour or whatever, have them take the lens out.
Yep, have them get up, have their coffee, take their shower, whatever, and like before going to work, take that lens out and leave it out, and let wear their glasses or whatever they're doing, and let that eye kind of recover, and then kind of like a retain in at night before going to sleep. So,
no, I love that. Joe, if we're caught up in questions, we can move on.
We're good.
All right. So we're gonna have fun with the rest of this. So the rest of this, we're gonna talk about keratoconus. To tell you how my keratoconus practice developed, it's kind of funny. I went to school in Boston, probably had zero experience with keratoconus up there in the school. But I was spoiled. I actually worked, in between my second and third year, I worked up at Corneal Consultants up in Boston, which was with an ophthalmology practice with Ken Kenyon, John Talamo. And they were probably the 2 of the most recognized corneal specialists in the world. And I got spoiled. I had an optometrist up there, Eleanor Mobilia. She was at the end of her career, and just by the nature of that practice, she had a lot of experience with keratoconus, which she was, nice enough and kind enough to share with me. So when I got out of school, I joined an ophthalmology practice in Connecticut, and I started treating keratoconus and started talking to some colleagues. And next thing I know, I'm starting to get referrals for this thing just because I was shocked at how many optometrists didn't want to manage this thing. And so I enjoyed doing it. It was excellent money, so I figured, why not? And that's how, I eventually got to the point where I was doing about 20 to 25 keratoconus patients a month, which was great. And to me, there's just no reason why any optometrist can do this. I mean, I certainly didn't get out of school with a wealth of knowledge about keratoconus. It's like everything in terms of how we practice. You learn the basics, you learn how not to harm patients, and the rest of it, unfortunately, you learn by trial and error as you see patients, clinically. So to me, we'll start keratoconus about, what's the worst thing you can do with keratoconus? It's the worst thing you can do with any condition. You miss the diagnosis. And Joe would be able to qualify this. The most reason why optometrists get sued is revolving diagnosis, failure to diagnose or delay in diagnosing. And that's true for keratoconus too. We probably don't get sued all that much for missing a case of keratoconus, but it's the most important thing you can do. Once you get the diagnosis right, then finding a way to manage a patient, is a little bit less problematic. And to me, what I've seen in keratoconus, what's the most common incorrect diagnosis when optometrists miss keratoconus? And it's easy. By far, it's amblyopia. And to me, that's just sheer laziness and sheer just not thinking. So when you think about amblyopia, we call it a diagnosis of exclusion. Even though it's a diagnosis of exclusion, you've got to have a reason for the amblyopia to develop. Right? There are three basic types of amblyopia. There's refractive. So if your patient doesn't have significant asymmetric refractive error, or they don't have severe bilateral refractive error, then your patient's not going to have refractive amblyopia. Strabismic, the same way. If your patient doesn't have an eye turn, they're not going to have strabismic amblyopia. If your patient doesn't have a congenital cataract or significant litosis, they're not going to have form deprivation. So what I see in a lot of patients that are referred into my centers, you'll see optometrists that are refracting typically a child, a teenager, patient, they can't get the patient to 20/20, and their diagnosis is amblyopia. And it's like, then you look at the refractive error, and it'll be -2 in the right eye, -250 in the left. Well, that's not amblyopia. You've got to have a reason why an amblyopia would develop. So once you think that through, and if your patient can't fall into a refractive strabismic or form deprivation amblyopia, then your patient doesn't necessarily have amblyopia. And see a lot of optometrists, they're referred in because they're not sure about the diagnosis. So let's talk about things we can do to confirm our diagnosis of keratoconus. Number one is our refraction. These are going to be kids that are going to be, usually they're teenagers. They're going to have large changes in their refraction, specifically in the amount of astigmatic correction they have. They're going to have huge shifts in axis, and they're going to have best corrected vision in the foreopter that's not 20/20. So all that's going to give you a clue that patients have something else going on rather than just merely a change in refractive error. Your retinoscopy, your standard, you're going to see your scissors motion if you're still doing retinoscopy on any of your patients. Your slit lamp findings. These are just some of the common slit lamp findings on a patient with keratoconus. So let's go over these. You look at these. These are your stress lines and deep stroma and Descemet's membrane. Look at that picture to the left. Looks like scratches on a window, right? That's your vote striae. You look at something like this, your iron deposition on your corneal epithelium. If you're having a hard time seeing it, put your cobalt blue filter in. It can help you identify these subtle lines. That's your Fleischer's ring. I rarely see it as a ring, so I don't know why it's called Fleischer's ring. Take your slit lamp, put it up to an optic section, put it up to high mag. A lot of times with people with moderate or severe disease, you can actually see the corneal thinning. You can see what helps you there is where the arrow is pointing. You get increased endothelial reflection, which is going to tell you how prominent the thinning is at that apex. You're going to get a lot of these patients that demonstrate prominent corneal nerves. Now this is coming out of optometry school in Boston in '99. This is all I really remembered about slit lamp findings in keratoconus, right? This is our classic Munson sign. So I get out of school, I start seeing a ton of keratoconus by default, and I'm looking for Munson sign left and right. And for the first couple of months, I'm like, wow, my slit lamp skills must be terrible because, I didn't see Munson sign on a lot of patients with keratoconus. Why not? because Munson sign doesn't happen in keratoconus, they're usually to advanced cases of the disease. So it's not usually going to be one of the presenting symptoms. So if a patient's going to have had keratoconus for a while and it's progressed for a while, yes, you're going to see Munson sign. But if you're seeing patients early in their disease, you're not always going to see it. And for that fact, you're not always going to see all these slit lamp findings on all your patients. Any of them you find, once again, it's just going to give you more information to back up your claim that your patient has keratoconus. Our keratometry readings, once again, if you're still using that, if you're using an autorefact, these are typically patients that are going to get an error because you're not going to do an autorefact on these patients. You're doing your K readings, you're going to get distorted Meyers due to the irregular corneal surface. You're going to get oval Meyers due to the amount of corneal astigmatism these patients have. And you're going to get that central ring, which is non-superimposable. Why? Because that keratometer is predicated on the fact that your patient has regular astigmatism, which your patients with keratoconus do not. The chemistry readings, something I do every year on my keratoconus patients. Average central corneal thickness is about 540, 550 microns. But in your keratoconus patients, you're not worried about central corneal thickness. So what you want to do is take that probe after you put a drop of anesthetic in. I will move the probe around on that patient's cornea, usually going slightly inferior, slightly nasal. You want to find the thinnest point on that cornea, and that's the number I document. And that's the number I track for changes over time, just to see, give me another value in terms of what, how that patient's keratoconus might be progressing. Easy thing you can do, a quick GPVA check. Put a drop of anesthetic in, take any gas permeable lens you have that's roughly equivalent to the base curve of that K reading, do a quick vision and overrefract. Here, you're not fitting a patient for management. You're not worried about 3-point touch. You just want a basic gross touch. If you can dramatically improve a patient's vision by doing this quick GPVA check, then there's a pretty good chance that your patient's issue is corneal and not retinal or not somewhere else in the eye. If you have a corneal topographer, your life is easy, right? This is based on this concept of placido disc and placido ring. This machine will shoot these beams of circular light into a patient's eye, will give you a color-coded map. If you have something like this, it makes it remarkably easy to diagnose. And not only does it make it easier to diagnose because of the color-coded map, it gives you more information. You know, a keratometer only measures the central 3 millimeters of a patient's cornea. With these corneal topographers, you can get further out than that and you give you a lot more information, which will help you confirm your diagnosis and will also help you management in terms of fitting these patients. That will take us to question poll number 4.
And you're all
Polling
caught up in the
question
questions,
is
Deepak.
open.
You're good. You're good on questions. You're all caught up.
Okay. How about you guys?
So
You guys doing any keratoconus fitting?
I do scleral lenses. I don't do any RGPs. What happens is we got plenty of people in the area that do kind of the hybrid lenses, the Rose K lenses, the soft lens RGP on top of that. I forget the name of that lens. But when it comes to the sclerals, just a handful in the area. So gotten pretty decent of doing nothing to sclerals.
Okay, cool. I don't do a whole lot with sclerals personally. I do a lot with Rose K2 IC. I'll do Dyna Limbo a lot. I like going large diameter on those specialty lenses, going up to about 9.5, 10 millimeters. I was terrible when I tried a couple of patients with sclerals, so I didn't do well with them. My success rate with the other lenses is about 95%, so I didn't really feel motivated to make myself get better.
Right. I can tell you how I ended up doing is, as you know, I have a lot of technology at the practice. I was able to take some wide field anterior segment OCTs. I had fit a lens on there. I was able to video with my I would take video with my slit lamp and send it off to a company in Colorado, and literally they would take. I would know how to pick the horizontal visible iris diameter, use a initial lens, but put it on there, do an over refraction, send them all that clearance after it's for about 20 minutes. They'd send the lens back and almost nail it. You know, it's one or two lenses. It was like name that tune.
Mhm.
They did most of the work by me just kind of send videos. So
Yeah, I find that same with just about all the keratoconus lenses. You know, you can call it Blanchard, which is now a division of Cooper Vision, and they've got these consultants who are just phenomenal. Or you can do the same thing: send your map in, send your K, send your refraction. And I'm always amazed at how well that, like you said, one or two lenses and probably 90-95% of your patients will be taken care of by you actually knowing very little. And I'm like, wow, these guys are really good at what they do on their end.
another 99%er. So we got amblyopia at 99%.
Cool. All right. So then we're ready to move on. And so once we've made the right diagnosis, to me, this is the next worst thing you can do. Remember, the worst thing you could have done is miss the diagnosis. We overcame that. And the next worst thing you can do, to me, is send the patient to an ophthalmologist. Why is that the worst thing? To me, ophthalmologists aren't going to be able to fit these patients with a contact lens. Like I said, I've been doing this 26 years. Probably 95, 96, 97% of my patients are managed optically. So if you're going to send to an ophthalmologist, that ophthalmologist is going to do one of two things. They're either going to turf it out to one of their ODs, or they're going to talk to a patient about surgery. And so let's talk about surgery for keratoconus, and we'll talk about that first. And to me, there used to be three options. There used to be PKP, Intacs, corneal cross-linking. Up our way, very few ophthalmologists are doing Intacs anymore. Most corneal specialists don't even like doing corneal transplants, but they will when they have to. Really, the bulk of surgery for keratoconus up our way has become corneal cross-linking. But we'll talk about both anyway. If you get any patient with keratoconus, who's gone online, they will come in and they're freaked out because, a lot of information out there online is about corneal transplants, and, they'll get scared about that, which they should. So to me, when we start talking about surgery for keratoconus, let's talk about, why patients get sent for surgery. And number one is the risk of perforation. And I think optometrists think, well, this is a patient that has this progressive disease. The cornea is going to thin out, and I've got to worry about it perforating. And that is true. In my 26 years, I've never seen a cornea perforate purely from keratoconus in the absence of trauma. So I've seen not a lot, some cases of perforated corneas, but not just due to a patient whose keratoconus progressed so rapidly that the cornea perforated. So that risk is not zero, but to me, that's still not a reason to send a patient out for surgical intervention. And we'll get a lot of consults for this, for scarring of the cornea. And I find that the vast majority of patients who scar down on their cornea is due to one of two things. One is they were abusing their contact lenses, or it wasn't properly fit. And this is where I think a lot of optometrists get complacent. They'll do a good job. Sometimes they'll fit the patient initially, and they'll get a nice stable fit, and the patient's got good vision, good comfort, and they'll say, all right, I'll see you in a year. 100% of my keratoconus patients I recommend seeing every 6 months, even ones that are stable. To me, you never know when a patient's going to have progression or some change in their cornea, and they have this potentially disease that's going to cause an issue. I would rather err on the side of caution in seeing these patients every 6 months instead of every year. That way, if their cornea is changing, that lens needs to be tweaked a little bit. They've only gone 6 months, maximum before that had to happen instead of a year. Sometimes that patient goes too long, that lens wasn't fitting properly anymore, and is rubbing against that cornea. That's what eventually induces the scarring. Once that patient has scarring of their cornea, corneal cross-linking isn't going to do anything for them. If their best corrected vision goes down so far from the corneal scarring, their really only option is going to be a corneal transplant, which is far less than ideal. Progression of keratoconus, which is one of the many reasons why patients nowadays are referred for surgery, namely for corneal cross-linking. Two specific patient groups that it happens in. A lot of it, the bulk of them is your teenagers, your 13, 14, 15, 16, 17, anywhere in that age range, where their keratoconus might be progressing relatively rapidly. The second population group is these women who get pregnant. A lot of patients with keratoconus, they'll be stable by the time they get to the childbearing years. And then all of a sudden they get pregnant, and the hormone changes associated with that pregnancy will sometimes cause some of these patients to progress. So to me, those are the two most common groups. I get this all the time. Patients that are sent to me or were sent for a surgical consult, which then the MD sent to me for this concept of GP intolerance. So I'm going to have a couple slides on this. And this is what optometrists would say, how they define GP intolerance. Right, a patient who's not able to wear a contact lens for the amount of time that he or she wishes to wear them. I got a little different definition. I think GP intolerance is way overrated. I'll get 4 or 5 patients a month that are referred to me for GP intolerance, and I can tell you almost 100% of those patients, I still end up fitting into a GP lens. Of all the patients I see, maybe 1, 2, 3 patients a year at the most who are actually truly GP intolerant. A lot of times it's just a matter of figuring out the right lens, the right protocol to get for your patient to make them GP tolerant. The vast majority of them haven't been prepared properly. So let's talk about how you prepare them. Number one, we'll talk about optical things in a second. Let's talk about practice management ways you can help decrease this concept of GP intolerance. Number one, you want to make sure your patient is properly motivated. So to me, I have a couple ways to do this. Number one, you want to wait for vision to be bad enough to motivate the patient. I tell patients up front, these lenses are going to hurt. I don't tell them they're going to be uncomfortable. I said they're going to hurt your eyes. It's going to be painful. You're going to have to get through the first couple of weeks. If you can do that, it will eventually become the most comfortable lens you've put in your eyes. Now, patients who are 20, 25, 20, 30, who are not unhappy with their vision aren't really going to be willing, in most cases, to tough out through that time period. So a lot of times I get these referrals for GP intolerance and the patient's 20, 25, -1, and I'll say, how happy are you with your vision? Doc, I'm doing great. I'm like, well, you're doing great, then we'll see you in 6 months. And that's not a patient who really needs to be put into a GP lens because they're probably not going to notice the benefit of being put into that lens and being able to deal with that level of discomfort. Number two, I talked to them about surgery. Most of them have already gone online. They've already heard about what a terrible procedure a corneal transplant is. I have no problem saying the same thing. So my goal at all costs is to have you avoid a corneal transplant, to avoid surgery. And lastly, I make sure my fees are high enough. I charge a ton of money for a keratoconus fit. Sometimes the insurance covers it, a lot of times it doesn't. And my contact lens fees are non-refundable. So that's enough motivation saying, look, you've already paid me. At this point, it's worth your time to try to force yourself to get used to these because ultimately it will work. And that being said, I also place some of that burden on me. I don't fit patients who I don't think are going to be successful. As much as I like making money and I like being in private practice, I don't like to take people's money who I don't think is going to be a successful fit. Ultimately, the patient goes home unhappy saying they spent X amount of dollars and they still didn't get anything for it. And that's not the way I want to build my practice. Optically, things you can do. Use a large diameter lens. So I was telling Greg, I'm not a huge fan of scleral, but I like large diameter. The Rose K2 IC is great. The Dyna Limbal is great. Whatever lens you're doing, I go up to a 9.5, 10.0 diameter. Why? Because most of the discomfort from a gas removal lens comes from the superior lid hitting the upper edge of that lens. You take a large diameter lens, now you can tuck the top edge of that lens under the superior lid. That's going to significantly decrease the amount that the patient feels the lens. Number two, be liberal. I went through a time period where I was just getting one patient after another that was uncomfortable in these GP lenses, and I would do punctal plugs on them pretty liberally. You can do artificial tears, you can do allergy drops to help their eyes more comfortable. No downside to plugging. If that helps them increase the tolerance of their gas removal lens, ultimately it's going to be in their best nature. And lastly, build up wear time slowly. The soft lens nowadays, you'll fit a patient in the soft lens. You'll say, yeah, wear it 6 hours today, 8 tomorrow. Within 2 or 3 days, that patient's wearing soft lenses all day. With these lenses, that's not the way it is. Sometimes I'll tell a patient, look, you might only wear these an hour. Not a problem. Your goal is to wear an hour one day, maybe increase 15 minutes every day, maybe a half hour. Take it slow. And as long as you can build that, you can do that. I find very few people are actually GP intolerant. So those are the reasons we send patients to surgery. Let's talk about the first one, the penetrating keratoplasty. You look up numbers, National Keratoconus Foundation estimates that 10 to 25% of cases need surgery. In my practice, that's way overrated. In 25, 26 years, I've sent maybe 6 or 7 patients for a corneal transplant. I think a lot of times if you catch these patients early, if you manage them aggressively and you keep them, like I said, on an every 6-month schedule in my case, just to make sure that they're not experiencing any problems, I feel the need for a corneal transplant is just way overrated.
Actually, Deepak, before you go too far into surgery, a couple things came.
Yes,
Two the same question came in. How often do you piggyback for
I
contact
never,
lenses?
I never piggyback. I've never fit a piggyback lens. I'll get a patient every now and then that already comes in on a piggyback, and I'll just renew that prescription for them. I find when I go large diameter in a specialty keratoconus lens, I've never had the reason to. For a while, I know people were piggybacking a lot. You had this company Synergize, which was out there marketing a commercially product, which is basically a piggyback lens. Once again, I never got good at it, never got motivated to it, just as my success rate with what I was doing was working pretty well.
And I think that's the answer, Deepak, is that, once you start going large diameter seems to be where, the cone has changed. They can't go for cornea cross-linking. There's a lot of distortion into the practice, and that's whenever I just kind of, in a sense, now just vault everything. That seems to be where the failure was in these feedback. And thank you for who brought that up. That is what I was trying to think of earlier. So,
Mhm.
any other questions, Joe?
Well, hold on. Well, here are two things. One, I think is going to be coming up. Do you send young patients for cross-linking, or it depends on the VA? Let's answer that one, or unless you're going to talk about that in a second.
I'm going to talk about that when we talk about corneal cross-linking, so I'll get to that one for
Okay.
sure.
And there's just another comment about a doctor in Columbus who is a big proponent of large diameter DALC, deep anterior lamellar keratoplasty, more so than cross-linking. That's just a comment. I'm not sure if you're going to cover that or not. I know that we have somebody in our practice who will do DALC, but it is not common. One of our corneal specialists really doesn't do it.
I haven't had too much experience with that. I haven't had too many in our area, and even when I was in Connecticut, if you sent to a corneal specialist, it was PKP or nothing. A
Hmm.
lot of the Delcs and stuff, they don't really work for advanced keratoconus from what I've seen. So, I just don't have that kind of exposure to it.
Joe, what is the sweet spot? Because, obviously cornea cross-linking is early in the condition, starting to progress, which Deepak's gonna cover, PKP, all right, nothing's working, transplant. Where does that procedure fit into advancement of
That's a good
keratoconus?
question because we do so little of it. So we have two corneal specialists, and one doesn't really do it that really at all. His wife does it, but I don't think I've come across a DALC yet.
Yeah, and it could be that the surgeon, not to say doesn't work in Ohio, that's just kind of,
Mhm.
what he grew up on and what he's comfortable with, or he is comfortable with. And, and that's what, that's their go-to instead of, maybe doing a PKP. That over the years, they just become really good at that, a procedure that's out there, but that's the case. But Deepak,
So,
I just want to let you know there's about 13 minutes. So just kind of gauge your presentation.
okay. So, Joe, real quick, the corneal specialist who's doing the corneal transplant, not excited to do corneal transplants, right?
Correct.
I've met a bunch of corneal specialists. None of them ever say, yes, this is a procedure I want to do. They'll do it as a last resort.
Hmm.
And that's kind of been my take, what I try to position it for in keratoconus in my practice. You're talking about 46,000 procedures a year. If you guys have never seen a corneal transplant, if you guys, I highly recommend you see it. You see it, it'll show you why I always call corneal transplant as my last resort in terms of keratoconus management. This is not the cataract surgery, which is 10 minutes and the patient's quick, one and done, and they're out. So what happens in this procedure, I put a couple of slides up here. Your cornea specialist is going to measure the size of that cornea. They're going to use this machine called the triphene, which is basically just a corneal cookie cutter. They'll place this on your corneal, they'll spin it, which is basically just making perforations out in that cornea. Then they'll take these scissors, they will go ahead and cut that cornea out. Then they will go ahead and physically sew that donor cornea into the host. And when you're done, this is what you're left with. You're left with one of two corneas. The upper left, sometimes these surgeons will use a continuous stitch, where they put in one stitch and just zigzags back and forth. Or sometimes they'll use the bottom right, basically a stitch every clock hour. And this is something that's visible to the naked eye. You don't need a slit lamp to see these stitches. But this is one of the many reasons why I don't like a corneal transplant procedure. Yes, it's necessary in some cases, but even though this patient is not going to have the inferior steepening that a keratoconus cornea would, they're still going to have these stitches pulling on it. You're still going to have an irregular surface. And I find upwards of 70 to 80% of patients, even when they have a successful corneal transplant procedure, it's still going to need a gas permeable lens in order to get optimal vision. To me, it's one of the many reasons why I say gas permeable intolerance is not a reason to send a patient out for corneal surgery, because they're going to be no less gas permeable tolerant, and they're likely still going to need a gas permeable lens after they have this procedure. And so what happens, like I said, patients are going to be on drops for months, for years, and sometimes forever. This is not a one-day cataract post-op where the vision's 20/20 -1 uncorrected. Patients are going to have fluctuating haze and vision for months, and I found this to be interesting. The median best corrected vision following a corneal transplant is about 20/60. So you've got to have a patient who's got keratoconus, who's going to be able to do the post-op drops for months, if not forever, who's got to be able to live with poor vision for 3, 4, 5, 6 months. And 6 months to me is critical. That 6 months is the earliest I've seen most corneal specialists will let you fit a patient into that gas permeable lens. And that's really where you can enhance a patient's vision. So essentially that patient's got to be able to live with fuzzy vision for up to 6 months. And I try to explain that to patients ahead of time. If you're going to send a patient for a corneal transplant, consult, explain all that to ahead of time and at least let them know what they're getting into. That being said, if you go do some research and you talk about the overall success rate of a PKP, this is a study done by Mass Eye and Ear where they went through some of their corneal transplant procedures, and you see the success rates here, 96%, 93%, 92.7%. And you look at this and you're like, well, if the success rates are so high, why am I saying that to me it's a last resort? Because you look at their criteria, how do you define a successful corneal transplant procedure? Very simple. A clear graft at 90 days. That's it. It doesn't matter what the vision is at 90 days. As long as there's no sign of rejection at 90 days, that's what most studies call a successful corneal transplant. Which is great in concept, great in marketing, but terrible in terms of the reality. And you fast forward, let's say these procedures are 93, 94, 94% successful at, day 90. What's the survival rate for a corneal after transplantation 1 year? Well, that's not really so bad. That's about 90%. Now you fast forward that number to 10 years. How many of those corneas are still viable 10 years after a corneal transplant? Only 60 to 70%. To me, that's terrible. You're talking about a third of the people who are going to have graft failure within 10 years. And the reason why it's terrible is because most people, if you're having a transplant because of keratoconus, you're not having it when you're 78 or 80 years old. You're having it when you're 20, 25, 30, 40 years old even, relatively young in life. So if you're saying a third of these people are going to go through this horrible procedure, they're going to have months without useful vision, and then they're finally going to turn the corner, and within 10 years, a third of these are going to fail. And when they fail, what's your option? Your option is to have another procedure done. So to me, my recommendation has always been to exhaust all options. So the vast majority of my patients, a lot of optometrists will say, well, I got to a point once I started getting referrals for keratoconus saying, before you send this patient for a corneal transplant procedure, let me take a shot at him, let me take a look at him and see what I can do. And what I found is probably 75, 80, 90% of them, people who optometrist would have sent for a corneal transplant, I was able to manage optically instead of surgically. How about we get to question number 5, and then we'll start with talking about corneal cross-linking. We'll end up with that tonight.
Sounds like a great idea. And the polling question is open. Which patient below would most benefit from corneal cross-linking?
And I cheated on this one. I cheated on this one. I haven't talked about this stuff yet, so.
All right. Well, some of the speakers put it before, some people put it after to see how they're doing. So we'll just change it up for number 5. Stable keratoconus, a patient with significant corneal scarring from keratoconus, a patient with rapidly progressing keratoconus, a patient who is GP intolerant. Joe.
I think we're pretty good.
Good. So let's talk about corneal cross-linking then. Conceptually, this is amazing, right? You've got a patient
Give me 1 second here, Deepak. I'm gonna give you the answer. I want to give them. So the answer that came the most, 72%, was C, a patient rapidly progressing. The runner-up was a patient with stable keratoconus at 16%, and then basically 6 and 8% was B and D.
Okay,
You're good.
So let's talk about corneal cross-linking, right? Conceptually, it's great. You got a patient with a weak cornea. Let's do something to increase the cross-linking between the individual collagen fibers. If we do that, we're going to strengthen the cornea, help the patient out. The main goal, what is FDA approved for, is to slow or halt the progression of keratoconus. So the ideal patient here is a patient who is having rapidly progressing keratoconus, and you want to slow that progression down. So who are the patients who are bad candidates? Patients who have prior herpetic infections. Corneal cross-linking does absolutely nothing for a patient who's already got a scarred cornea or a pacified cornea. And I think optometrists sometimes don't get this. They think, okay, the patient has some scarring on the cornea. I don't want to send them for a corneal transplant. Let me send them for corneal cross-linking. Corneal cross-linking isn't going to do anything for that patient. Patient with a history of pore winding, autoimmune disease. And this last one's interesting. A patient with a cornea that's less than 400 microns. So 400 microns is the cutoff where most surgeons want to do corneal cross-linking. Once the cornea gets to be thinner than that, you risk damage to the corneal endothelium by doing this procedure. So what do you think most cornea specialists do when you get a patient who's been sent for corneal cross-linking, whose cornea is less than 400 microns? Very easy. You instill some hypotonic solution, you induce corneal swelling, you do that, now that corneal thickness comes up to above that 400 number, you'll go ahead and do the procedure, then you add the hypertonic solution in the post-op to get all that extra fluid out of the cornea. Procedurally, very easy, right? Yeah, put some anesthetic in, use usually this machine called the scrubber to remove the corneal epithelium. You do that, then you instill these riboflavin drops every 5 minutes for roughly a half hour. Once you've got a high enough concentration there, you use a UV light to stimulate that riboflavin. That riboflavin acts as a catalyst then to try to help increase the cross-linking between the individual corneal collagen fibers. Post-op, it's kind of like what was back in the PRK days back of 20 years ago before LASIK became a hit. Patients going to typically go home with a bandaged contact lens on their eye. They're going to have discomfort for at least 3, 4, 5 days. It's going to take 2 to 6 months before that vision return to baseline. It's not unusual for that vision to get worse before it gets better. Limited number of insurances are covering this thing. Most of them do not. So you're talking about $3,000 or $4,000 out of a patient's own pocket, in terms of what it costs. Results, most studies show it's highly effective in terms of slowing down the progression, but not 100% react to this. You look at the numbers here in terms of how many patients don't change. The Kmax is what I look at the most. 40% of the people, their K doesn't change with corneal cross-linking. I was very fortunate or unfortunate, I should say, when corneal cross-linking came out. I was down in Connecticut in my practice in Milford. We had 2 corneal specialists, Seth Meskin and Eric Donenfeld, who were doing the clinical studies. This is before corneal cross-linking was FDA approved. So I got a huge amount of experience with some of these patients. And so what I found is, you look at these complications and you think, well, that doesn't happen all so often. You're right, it doesn't happen so often. But think back to the population group and who you're sending this to. Most patients, you're sending this because their keratoconus is progressing. And Joe, this is going to go to the question that was asked about when to send for corneal cross-linking. Let's skip this for a second. I'm not a huge fan of corneal cross-linking. When I saw a lot of these patients for the FDA clinical trials that Seth Meskin and Eric Donfeld were doing, most of them do pretty well. It's like any surgical procedure. But the ones that don't do well, don't do well. And the way I look at it is progression is most common in teenagers, right? These 13, 14, 15, 16, relatively young kids. They're progressing rapidly. And to me, I'm not a huge fan of sending patients out for a surgical procedure when they're young. In my practice, I know in my mind, the way I look at it, and I'm not going to limit a patient's options. I will always talk to a patient about all their options. But I know progression is for a finite period of time. I know with my skills, I'm confident enough to say I'm 100% sure I can fit these patients. And if they're going through a time period where their keratoconus is progressing rapidly, I'll see them every 6 months. Sometimes I'll see them every 3 months. And I'll say, look, I'll refit you every 3 months if I have to. I'll do that for a year, for 2 years, for 3 years. At some point, I'm reasonably sure that keratoconus is going to stop progressing. And if you want to talk about pure safety, I think it's safer to do that than it is send a patient for a procedure, because like every surgical procedure, it has its costs, its risks, even though it's reasonably safe and it works well in most patients. When it doesn't, and I remember a couple of kids I saw in my practice in Milford who had this procedure done, who got some corneal scarring. So now at 16 years old, your best corrected is 20/30, and now for the rest of your life, that's the best vision you're going to get. Because once your best corrected is due from corneal scarring, your choices are to live with that decreased vision or to undergo a corneal transplant. To me, neither option is great. So it doesn't mean you limit a patient, because I'll never limit what a patient does, but I'd rather, my protocol for progression is I'll see a patient every 6 months or sooner, keep changing the fit to adapt to that progression, knowing that it's going to be for a finite period of time. And I'll always educate the patient. I'll tell them about all their options and tell them how to proceed. Let's go back to slide 2. So when we talk about corneal cross-linking, what's new is the newest variation is the biggest danger of doing corneal cross-link is removing the epithelium. Newest procedure, Glaukos just submitted for FDA approval, is doing this procedure without removing the epithelium. And of course, that comes at a cost. So it becomes a much safer procedure if you don't remove the epithelium, but you're probably not going to get quite the same amount of control and progression as you do with removing the epithelium. And if we can not remove the epithelium, then the next battle will be, will ODs be allowed to perform it? And lastly, what Glaukos is looking into is, if you're not removing the corneal epithelium, what about just using riboflavin drops? Or what about increasing the nutritional intake of riboflavin? Will that help slow down the progression of keratoconus? Studies are pretty early, but it looks pretty good. You certainly don't get the same amount of control as you do this corneal crossing procedure, but just by using riboflavin drops 4 times a day is what they're looking at. Maybe that will be enough for people who don't want to undergo surgery to try to help control their progression. And that is all I got. 921, Greg. How's that?
Nailed it.
Very good.
Perfect.
Very good. We
My
consider that
comment that I
well
like
done.
to cornea cross-linking is Deepak, as you know, because I've been to your meeting, the hand scanner, antioxidants, trying to prevent aging, and pointing out to the audience that this is aging in reverse. If you think about it, we are taking someone's cornea, soaking it in riboflavin, exposing it to sunlight. We've all seen those twins, one adult twins, one that the epigenetic change where one is because they've been in the sun a lot, and the other one hasn't, and they have the exact genetics. So we know sun is damaging the cross-linking, and here we're taking something that in a sense could be bad, but used in a positive way to cross-link and stiffen that, staring at the sun in a sense with that UV light for 30 minutes, literally aging that eye and cross-linking it. So kind of a cool reverse of anti-aging. So, Joe, any other questions that are there?
Nope, nothing for Deepak. We're good.
Cool.
Okay, so everyone, if you look at your screen, you'll see that there's a little red dot right here. You can see that survey that is required. So please do that in this synchronous event. With that said, I'm just going to say, Deepak, before ending the education here, Deepak, thanks for doing this. That looks like a lot of questions are answered. This is anterior segment disease conditions every optometrist should be managing. I think it was done. Great overview. Hopefully encourage a lot of our colleagues, or some refresher for them to go out and maybe manage these in a little bit more confident way. But I'll let you make any comments, and Deepak.
So thank you, everyone, for spending the evening with us. Joe and Greg, thank you so much once again for letting me be part of your wonderful meetings, and thank you.
Well, we're really happy to have you. For people who don't personally know Deepak Gupta, he is really one of the gentlemen of the profession. He's just a terrific guy and a great presenter, and with a wealth of good clinical knowledge. So, Deepak, thanks so much.
Thank you. You guys have a great night.
And keep us in the loop on that movie that's coming out. We'll blast it out, let everyone know. So.
Oh, thanks. Appreciate it.
Movie producer. All right. That will conclude the education for tonight. Thanks, everyone.